Bismillahirrahmanirrahim. Assalamu alaikum and good evening, everyone. And I would like to thank the organizing committee for inviting me. So I've been asked to talk about amyloidosis. So I'll start with a case of mine, one of my patients. Okay. So this is a 31-year-old gentleman who came with a 4-month history of respiratory symptoms, cough, hemoptysis, chest pain, dyspnea, and fatigue with significant weight loss and constipation. So he visited many hospitals and was treated with multiple courses of antibiotics, thinking that this could be bronchitis, but no improvement. Eventually, a CT chest done, which showed multiple lung nodules with mediastinal lymphadenopathy. So he underwent bronchoscopy, and all of the microbiology workup came back as negative. Also, his CT abdomen pelvis showed GI or mucosal thickening, and underwent scope, which showed the fibril mucosa, easy to bleed. So multiple biopsies were taken from his GI tract, and which complicated also by bleeding. The interesting thing about that, so the biopsies actually showed evidence of amyloid deposition with a positive Congo red stain. Also, a CT-guided biopsy was taken from one of these lung nodules, which also showed the same thing. So there was amyloid deposition in his lung nodules. He underwent echo, which showed left ventricular hypertrophy with thickened interventricular septum with preserved ejection fraction. So he was referred to us, and by clinical examination, he looked chronically ill, very cachectic. His blood pressure was fine with no orthostatic drop. Saturation was fine. There was no organomegaly, and otherwise the rest of the exam was fine. His lab showed actually elevated BNP at 265. And his troponin was, troponin was 214, but there was no nephrotic range or no proteinuria in general. He had abnormal kappa lambda, so lambda was 153, and abnormal ratio, as you can see, 0.05. This is actually a picture of his ECG, showed low voltage, as you can see. And we did a PET CT on him, which showed diffuse uptake in the GI tract, with some lymphadenopathy and multiple lung nodules. He had also a cardiac MRI, which showed preserved ejection fraction, but thickened ventricular septum with of 1.5 centimeter, and evidence of hypertrophic cardiomyopathy on imaging. So bone marrow biopsy done for him, and it showed plasma cells of 10 to 12%. Some of them had abnormal forms on morphology, and his bone marrow also was positive for Congo red stain around the blood vessels. So, final diagnosis, AL amyloidosis with involvement of the heart, GI tract, lungs, and bone marrow with significant plasma cell population, but he did not fit diagnosis of multiple myeloma since there was no CRAB features. So he was started on DARA VCD, and after the first cycle, he had significant improvement in his symptoms. So all of the respiratory symptoms were gone. And after 2 cycles of DARA VCD, he achieved complete hematological response with normal kappa lambda ratio and difference in the free light chains of less than 10, and patient was able to go back to work as a full-time. So amyloidosis. So basically, this is the way how I describe it to my juniors, that this is a misfolded protein that act like a glue. So it sticks to any organ and causes organ dysfunction. So the problem with that, as I will show you, it doesn't have any specific feature because it depends on which organ involved. So, but we need to remember that not every amyloidosis is AL amyloidosis, because there are other forms of amyloidosis that we have to differentiate between this and that. So, for example, the transthyretin amyloidosis, which mainly affect the heart, and the AA amyloidosis, which happens with chronic infection, which affect mainly the kidneys. It's a rare diagnosis, so it affects about 10 person in 1 million population. It's mainly affect elderly people, but you saw in my case, the patient was 31, which is very unusual as a presentation of AL amyloidosis. More commonly, it's lambda, so whenever you see lambda light chain, think more about amyloidosis as well. It's a great mimicker, so it can, as I mentioned to you, it can present in any way, so there is no specific presentation. So it can present as symptoms of heart failure, and the differential diagnosis is quite huge. It can present with GI bleeding, peripheral neuropathy. So you have to keep your differential diagnosis broad and think about it. The problem with that, it's been reported that there is always a huge delay in getting the diagnosis. Most of the patients get diagnosed after 2 years of starting the symptoms, which is result in significant delay and worsening of the patient's clinical condition. So by the time we get to the diagnosis, the patient had already end organ damage that might affect his prognosis or affect the choices of therapy. It can affect multiple organs, heart with evidence of cardiomyopathy, arrhythmias, sudden cardiac death, GI tract, which can lead to GI bleeding, organomegaly, liver dysfunction, involvement of the kidney in form of nephrotic range proteinuria, renal failure. It can affect the nervous system with different either motor, sensory, or autonomic neuropathy, as you've seen. So renal involvement, this is one of the most common presentation. It mainly presents as asymptomatic proteinuria, but it can lead to a nephrotic range proteinuria. Cardiac, also it happens in 60% of the patients in form of restrictive cardiomyopathy or hypertrophic cardiomyopathy. Usually there is involvement of the intraventricular septum, so that's something must be examined well during echo or cardiac MRI. As you can see here, there is significant thickening of the intraventricular septum in the upper echo, as you can see here. So also the late subendocardial enhancement on cardiac MRI. This is one of the features that goes with such diagnosis. One of the issues with cardiac amyloidosis is the arrhythmias that might happen in these patients, leading to sudden cardiac death. And that affect even the choices of therapy. So medications like amiodarone or digoxin, it can put the patient into higher risk of arrhythmias. So you have to work with an expert cardiologist in that regard. Elevated N-terminal BNP or troponin associated with higher cardiac morbidity. Peripheral neuropathy, as I mentioned to you, it can be motor, sensory, or autonomic. And patient can also present with compression neuropathy related to carpal tunnel. So how we approach a patient with suspected AL amyloidosis? First, we need to confirm that there is an amyloid deposition. Then we have to specify what kind of amyloid, because not every amyloid deposition is AL amyloidosis. And then we have to identify the organ involvement, because by that, it affects the patient prognosis and choices of therapy, and look for underlying causes like myeloma or lymphoma. So how we confirm the amyloid deposition? The simplest way is by the congruent stain. It has acceptable specificity, but not very sensitive. The golden standard is actually mass spectrometry, but the problem, it's not widely available. So that's why immunohistochemical staining and electron microscopy could be an option, especially if the clinical scenario goes with diagnosis of AL amyloidosis. Also, there is an important hint, presence of clonal plasma cell disease. So finding a clonality of plasma cells in the bone marrow or abnormal kappa lambda ratio, that's a hint that there is ongoing plasma cell disorder that support diagnosis of AL amyloidosis. Organ involvement, extensive workup with history, physical examination, echo, cardiac MRI, liver testing with ultrasound. endoscopy sometimes needed, and nerve conduction study with possible nerve biopsy. You have to look for underlying cause, multiple myeloma, or other lymphoproliferative disorder like Waldenstrom. This is something need to be done. So these are the diagnostic criteria for diagnosis of AL amyloidosis. You have to confirm, as I mentioned to you, the amyloid deposition, the clonality, and you need to rule out other causes. So something I want everyone to remember, so if you have someone newly diagnosed myeloma, MGUS, or smoldering, as part of the workup, you have to make sure that there is no clinical evidence or biochemical evidence of cardiac amyloid. So it's been recommended for any newly diagnosed MGUS, smoldering myeloma, you need to do the NT-proBNP, troponin, 24-hour urine for proteinuria, just to rule out presence of amyloid, plus the history and physical. So in your interview with the patient, you have to ask about all of the symptoms that might suggest presence of AL amyloidosis. So prognosis-wise, so there is multiple, so based on the organ involvement, but the most commonly one that we use in our clinical practice is the second one, because it's involved the use of BNP. In most of our hospitals, we don't have the NT-proBNP. So if the cut limit of 700 or more, it tells you that this patient is more advanced and associated with a worse prognosis. As you can see here, the difference between patients with different stages. The stage 4 has a very worse prognosis, up to survival of 6 months only. The same thing also with renal, so more renal involvement affect the patient prognosis significantly. This is actually summarizes the response criteria based on which organ involved, and also it tells you how can you define the progression if the patient has responded initially. So what's the goal of therapy? So the therapy of AL amyloidosis, the most important goal is to suppress that clone of plasma cells that produces this misfolded protein. By this way, you are giving time for the tissue to recover from the injury that has happened. And this is best achieved if we achieved a very deep response with involved free light chains of less than 20 and difference of free light chains of less than 10. So remember these numbers. We need to be as deep to reach to that, because that is associated with better prognosis. Management include multiple teams based on the organ involvement. It's not only a hematologist, so it has to be worked. Patients with amyloidosis need to be treated in a tertiary center where expert multiple specialties can be available. So in the old days, conventional chemotherapy was the way to go. So melphalan with Dexa was the standard of care, but that associated with more toxicities, so like secondary leukemias, and even the response rate was not best until the proteasome inhibitor came, and then the VCD became the standard of care with response rate reaching up to 80%. But can we do any better than that? So that's actually achieved with the addition of DARA. So DARA VCD with the Andromeda trial. So newly diagnosed AL amyloidosis with multiple organ involvement and absence of myeloma, they were randomized to receive either VCD or DARA VCD, as we can see here. And the results were quite impressive. So almost the response rate was 100%. And most of the patients achieved the VGPR. And this is what we need to achieve, because patients who achieved VGPR, regardless what they receive, they do better with AL amyloidosis. Transplant is always encouraged to be done, but you have to select your patient carefully. So patients who are excluded if they are elderly, poor functional status, a significant cardiac involvement with drop in the ejection fraction, or there is some reports with the intraventricular symptoms of more than 1.5, because that's associated with worse outcomes. Liver impairment with bilirubin of more than 2, and eGFR of less than 50. If there is abnormal cardiac enzymes, that gives you a hint that patients might have a higher transplant-related mortality. You need to consider reducing the dose of melphalan if you are taking the patient for transplant, and transplant must be done in expert center because transplant-related mortalities in these patients are higher. But if that's done successfully, the reports show that these patients, they do very well with overall survival of more than 13 years. Maintenance therapy, there are no consensus. In the Andromeda trial, they included DARA maintenance of 2 years. But after that, nobody knows what to do, and there are no consensus about doing maintenance. But if there is associated myeloma, definitely maintenance therapy would be indicated. So there are some special considerations that I'm going to mention. So cardiac amyloidosis, so you have to be careful, especially if they are stage 3B. These patients, they do poorly in terms of tolerance to therapy. So try to avoid DEXA, because that can worsen the heart failure symptoms, or at least reduce the dose. There are some suggestions that DARA as a single agent for advanced cardiac amyloidosis might be a better option. Neuropathy, you have also to be careful with the use of bortezomib, so reducing the dose or avoiding bortezomib at all. Other options can be considered lenalidomide, daratumumab-based therapy. Also with liver dysfunction, since bortezomib, lenalidomide, and alkylators all can be metabolized by the liver, and also added the hepatotoxicity. So if there is advanced liver dysfunction, stay away from these medications at the beginning at least. Use single agent DARA, and then you can escalate your therapy. Patient requiring dialysis, this is not a contraindication for transplant. But if the patient have a heavy proteinuria, remember that daratumumab is a protein, so it will be excreted in the urine, so that might affect the efficacy of daratumumab. If you are dealing with IgM amyloidosis, so here this is most likely related to a non-Hodgkin lymphoma, so the treatment option would be rituximab based as rituximab bendamustine, or rituximab bortezomib as an option for these patients. Relapse refractory setting, so what the definition of relapse in these patients? So it would be clinical, but I think the most important and the one that trigger our treatment is biochemical, because you don't want patients with relapse to come to you with end organ damage, because prognosis in these patients are very bad. So there are some suggestions that once you have these figures, so difference of free light chains of more than 20, or increase up to more than 20% from the baseline, or 50% from the best response you have achieved, initiate therapy. The option would be, there are also no consensus, but proteasome inhibitor like ixazomib has been shown efficacy, as you can see here, in more than 50% of the patients. Immunomodulatory drugs also of help with these patients, although the tolerance in these patients are low because of the GI intolerability. So we have the options lenalidomide, but the data from the pomalidomide showed superiority. Try to use a dose of 2 milligram, not 4 milligrams, since it's better tolerated with that group of patients. Monoclonal antibodies also, as it's shown, effective in the upfront. It's effective in the relapse refractory setting. There are some newer agents that being in the use of phase 1 and phase 2. So the monoclonal anti-SAB, the SAB depleting agent, and anti-fibrin monoclonal antibodies. But unfortunately, there are some unfavorable risk-benefit profile and fatality with these agents, which affected the use of these medications. So this is just to summarize what I've said. This is my conclusion. So for patients who are low risk, consider induction with a Cyborg-D or DARA Cyborg-D, as you should, with the newer data. Consider stem cell transplant with melphalan. For patients who are intermediate risk, also the same thing, but you have to be careful. You might need to adjust the doses of your medications. For high risk, definitely they will not be transplant eligible. You can use agents like single agent daratumumab, reduced doses of bortezomib and dexamethasone for that group of patients. For relapse refractory, so it depends on the case, but pomalidomide, ixazomib, monoclonal antibodies, all are available options and showed efficacy. Thank you, and happy to take any questions during the discussion.